Karibuni, salams. I'd say good morning, good afternoon, good evening, wherever you are. I'd like to welcome each and every one of you on behalf of the Brain and Mind Institute and the Institute of Global Health and Development. It is such an honor and a privilege to have Sir Professor Michael Marmot with us today. I want to start by welcoming him and providing a bit of an overview about the BMI, the Brain and Mind Institute, as it's a new institute at the Aga Khan University. We could not have wished for a better champion with us here today of empowering social change, especially now, given the evolving understanding of the impact of COVID pandemic. I'm sure you all have read his bio and so know his amazing work. He has done and continues to do, and we look forward to hearing his ideas about how we as entities or as global communities can transform some of those ideas into action. The Brain and Mind Institute is a newly minted institute housed within the Aga Khan University. And the Aga Khan University is a global university with campuses in 6 countries, serving East Africa, South and Central Asia, and the UK. Brain and Mind Institute has 2 hubs, one in Nairobi, serving East African countries, and one in Karachi, serving South and Central Asia. Brain and Mind Institute focus is on mental health and brain or neuroscience. In this context, Brain and Mind Institute is very interested in addressing health inequities. We subscribe to the World Health Organization's ethos of there is no health without mental health. Brain and Mind Institute is launching a series of practice and policy flagship talks that address the key social determinants of health across AKU geographies in partnership with the Institute of Global Health and Development. We want to focus on health disparities and vulnerable populations, such as those living with HIV or young people with comorbidities, living in poverty, and exposed to experiences of marginalization. We have prioritized articulation of lived experience in our outreach in communities and clinical contexts, and we are also focusing on a systematic study of the environmental and biological risk factors that perpetuate mental health illnesses. We want to come together also to mobilize the national networks, especially in Pakistan and East Africa, to champion mental health, addressing social determinants of health in AKU-related geographies. Let me share a little story from yesterday that in a small way illustrates the challenges faced by marginalized individuals under resource constrained settings. Just yesterday, I returned from a coastal area of Kenya called Kilifi, where we are tracking the health of 92,000 households, mostly rural and some urban. In Kilifi region, what struck me when I went there were big billboards announcing easy access to 5G networks, which I don't even have in Ottawa, Canada. However, there is no running water in most households. Many women and children were spending up to 8 hours a day walking to the distant water source with their jerry cans to bring water to their homes for cooking and cleaning. Women having to walk even further now because of the drought and shrinking water supplies. We are seeing negative health and mental health outcomes. I actually tried carrying 2 jerry cans of water, and believe me, it is a demanding job. This job is ascribed to women and children. Now, how do we rationalize access to 5G networks, but no access to running water in this day and age? But let me not digress too much and get to the interesting speakers and panelists. Let me introduce Dr. Manasi Kumar. Manasi is a senior implementation scientist and mental health specialist with the Brain and Mind Institute, with a background in social determinants of adolescent maternal mental health in those geographies. So Manasi, over to you.
Thank you very much, Zul. And I'm here to introduce Professor Michael Marmot. And it is really my pleasure and honor to welcome you, Sir Michael Marmot, to the Brain and Mind Institute. and to this 2022 webinar that is in partnership with Institute of Global Health and Development. You've just seen Dr. Bhutta here, who leads the institute, and both institutes are housed within the Aga Khan University fold. A lot has been published by Professor Marmot. I just want to point out to a few things here that I think are important, preface to his important talk. Professor Marmot has been a professor of epidemiology at UCL since 1985. He's the author of two very important books that I highly recommend you all to read, but there's a whole other literature that's available there. So The Health Gap, The Challenge of an Unequal World, Bloomsbury 2015, and The Status Syndrome, How Your Place on the Social Gradient Directly Affects Your Health, Bloomsbury 2004. Professor Marmot is the advisor to the WHO Director General on the social determinants of health. He has led several research groups on health inequity since nearly 50 years. He chaired the Commission on Equity and Health Inequalities in the Americas, set up in 2015 by the World Health Organization's PAHO, the Pan-American Health Organization. He was the chair of the Commission on Social Determinants of Health, which was set up by the WHO in 2005, and produced a report entitled Closing the Gap in a Generation in August 2008. In 2020, UCL's Institute of Health Equity that Professor Marmot launched in 2011 produced a report called Build Back Fairer, COVID-19 Impact Inquiry, also known as Marmot Review, to investigate how the pandemic has affected health inequalities in England. I have just finished reading The Health Gap, which I highly recommend to you, as I've said before. And there, Professor Marmot writes how medicine is a failed prevention, and points to the need to understand social disadvantage by studying the causes of causes. Professor Marmot writes that disempowerment has material, psychosocial, and political elements. The psychosocial is the lack of control over one's life. I say this because many of us here are mental and behavioral health researchers and clinicians. In this book, reflecting on in the book on the health gap, the chapter around organization of hope towards the end of the book, he talks about the triangle that moves the mountain, that is the government, the academia, and the knowledge, and the people. We hope he will illuminate us about inequities, but also tell us more about this triangle that moves the mountain and how to make it work better in these challenging times. So I would like to invite Professor Marmot to deliver his talk entitled Social Justice and Inequity. You have 30 minutes, which we'd like to follow up with 5 to 7 minutes of Q&A. And we will then hear remarks from Professor Bhutta, who I will introduce. Professor Marmot, over to you, sir.
Thank you very much. And it's a great pleasure to do this, particularly given the news today. It brings home how important global participation, global cooperation is. We are an antidote to the forces of darkness and evil. The fact that we share our knowledge and understanding, it makes this even more important. And my title, Social Justice and Inequity, I will of course talk about the social determinants of health. And as I've said many times, that anyone concerned with the social determinants of health has to be concerned with mental health. And anyone concerned with mental health has to be concerned with the social determinants of health. So as I go through what I have to say, bear in mind that mental health is an outcome. You mentioned my book, The Health Gap. I quickly inserted this. The opening line of my book was, why treat people and send them back to the conditions that made them sick? When you talk of health inequity, in most countries of the world, people quickly turn to the health care system for very obvious reasons, because of lack of access to health care in most countries of the world. And it's right to be concerned with the health care system, but my concern is with the social determinants of health, the conditions that make people sick. I could have called this Build Back Fairer. It's the title I've given to 4 reports over the previous year, one in England, Build Back Fairer, then the Commission on Social Determinants of Health in the Eastern Mediterranean region. We reported in March 2021. We called it Build Back Fairer, Achieving Health Equity in the Eastern Mediterranean. And then for Greater Manchester in England. And the fourth was for Hong Kong. And the reason I mention these is because action can be at a national level, England, at a global or supranational level, the Eastern Mediterranean region of the World Health Organization. It can be at a subnational level, Greater Manchester, or whatever you call Hong Kong, a jurisdiction within a larger country. After the WHO Commission on Social Determinants of Health, which I chaired, I was then asked to lead regional commissions, firstly in the European region, then in the Americas, and lastly in the Eastern Mediterranean region. I'm still hopeful that we might do something in the African region of WHO, hence my enthusiasm for speaking in Nairobi today. This was the conceptual framework. If you're familiar with the conceptual framework of the Commission on Social Determinants of Health, you can see the link in the structural drivers, and we had chapters and recommendations relating to each of these topics. Particular to that region, conflict and its consequences, economic and commercial determinants, culture and society, the natural environment. And in the conditions of daily life, maternal and child health, early years, education, employment and quality of work, healthy aging, built environment, health systems. The outcome is health equity and dignified lives. We were particularly concerned with the position of migrants, refugees, and gender, as well as socioeconomic inequality. And I'll explain this. Do something, do more, do better. The principles of taking action, governance and political cultures, policies, research and monitoring. The Eastern Mediterranean region, so-called, stretches from Morocco at the very western end of the Mediterranean, North Africa, not Algeria, which is Afro, North Africa, the Middle East, not Israel, which is in Europe, Djibouti, Somalia, and then keeps going. Iraq, Iran, Afghanistan, and Pakistan. I guess India and Pakistan are in different regions for political reasons, as is Israel and the surrounding countries. What do I mean by do something, do more, do better? Here's the Preston curve. Gross national income per person, adjusting for purchasing power, and life expectancy. If Afghanistan, leaving aside the current tragedy of Afghanistan, but where we were in March last year when we published, if Afghanistan increased its national income to that of Pakistan, it's likely that its health would improve towards that of Pakistan. If Pakistan's national income went up to that of Egypt, it's likely that its health would improve, life expectancy. And then once you get up to this level, Jordan, Lebanon, and thereabouts, around $15,000 to $20,000, adjusting for purchasing power per person, gross national income, and go all the way out to Qatar at greater than $90,000. For reference, the US is around 60. There's simply no relation between national income and life expectancy. If you're poor as a country, it helps to have more money. There's things you can do. But once you get up to, let's say, $20,000 income per person, getting rich is not the way to get healthy for a country. Action on the social determinants of health is what's important. So we were concerned with these inequalities between countries and concerned with inequalities within countries. Under 5 mortality rate by quintile of wealth, and a very clear social gradient. And it's not just that the poor have high under 5 mortality, it's graded. In Pakistan, even the richest wealth quintile has higher under 5 mortality than the bottom quintile in Egypt. So we need to be dealing with the inequalities within countries and with the whole level. And that leads to the idea of do something, do more, do better. Primary school completion rate. I'm back in EMRO now, in the Eastern Mediterranean region. Primary school completion rate by wealth quintile. So in the occupied Palestinian territory, nearly 100% of children complete primary school. In Tunisia, it's graded by wealth, dramatically so in Iraq, in Pakistan, in Yemen. Do something. All of these children should complete primary school. And you can see how low it is in the poorest wealth quintile in Pakistan or in Iraq, just over 50%. Do something. Do more. Lower secondary school completion rates. There's the occupied Palestinian territory, pretty high, but something of a gradient. Jordan, yep, very high for the richest wealth quintile, but a clear gradient. Sudan, Iraq, Afghanistan. So do more. Yes, getting children to complete primary school is a basic. Now, what about completing lower secondary school, which should also be a basic? So do more. Do more. This is the percent of women who agree that a husband is justified in hitting his wife. This is women who agree that a husband is justified in hitting his wife. In Afghanistan, 80% of women with no education agree that a husband is justified in beating his wife. In Morocco, similarly. But the greater the education, the less likely are women to endorse that proposition, with catastrophic impact on physical health and mental health from domestic violence. Do better. Yep, educate women, have women in the workplace. Now, this is wage equality for similar work. In Egypt, in 2014, women earned just less than 80% of what men earned for similar work. And by 2018, it had gone down, it got worse. Iran, it didn't change, but it was low, women earning less than 60% of what men earned for similar work. So do better. Start getting gender equity in the workplace. Structural drivers, and I'm not going to go through all of these in detail, just to refer to them, but conflict and its consequences. The number of refugees in selected host countries and territories. In Jordan, Jordan is hosting nearly 3 million refugees. Jordan is not a rich country. Look at the burden that places on the host country, Jordan, and the conditions in which the refugees are living. Occupied Palestinian territory, more than 2 million. Lebanon, 1.5 million. Pakistan, more than near 1.4 million. Huge impact on the health and well-being of the refugees, as well as the burden on the host country. And that's, in large measure, a consequence of armed conflict within the countries. Economic and commercial determinants. When we did our review in the Americas, they said, we are the most unequal continent. This is the share of pre-tax national income among the richest 10%. So in Latin America, the richest 10% had 54% of national income. In sub-Saharan Africa, it's actually more unequal. And in the Middle East and North Africa, more unequal still. It's pretty unequal everywhere. In Oceania, it's less so. Interestingly, we think of North America as being grossly unequal, but less than in all these other regions except Europe. Culture and society. Global evidence shows that religious practice is associated with good health, and faith-based organizations in the Eastern Mediterranean region provide essential services and funding to low-income and excluded communities. There's no question that religion can be a force for bad in the world, but we drew attention to the fact that religion can be a force for good, both religious practice and faith-based organizations. And thinking about culture, coming back to the slide that I showed you, there could be a view that we should be culturally relative. Say, well, that's the way they do it in those cultures. The view we took was that the human right of women not to be abused by their male partners was more important than being culturally relative. There's an absolute imperative of the human right of women to have psychological security, bodily integrity. So this is part of dealing with culture. The natural environment, of course, climate change and its consequences, but biodiversity, air pollution, and the like. And thinking of climate change, this is share of benefits from electricity subsidies by income quintile. In Iran, in Jordan, Lebanon, the richer you are, the greater your share of electricity subsidies. What? In the context of a climate crisis, we're subsidizing rich people to use more electricity? Surely we should be thinking about a certain basic level of electricity as being close to a human right and subsidize that, and then penalize people who use more. Got it the wrong way around. Conditions of daily life, we had recommendations on all of these. Employment and quality of work. Informal employment as a percentage of total employment. Sudan, Morocco, Iraq, a very high proportion of people in informal employment, which damages physical health and damages mental health. And then the impact of COVID. Pre-COVID projection of extreme poverty, $1.90 a day in the region, was that it would go down. The COVID-19 baseline projection is that there would be a very clear increase in extreme poverty. And percent of workers who stopped working as a result of COVID-19 by wealth quintile, Djibouti, Egypt, Tunisia. And you can see this in country after country. The pandemic increased social and economic inequality. And we said on the cover of the WHO, Closing the Gap in a Generation, Social Determinants of Health Commission, social injustice is killing people on a grand scale. I would apply that to all the work we've done in the regions and countries. But let me turn my attention now more specifically to mental health. This is the Brain and Mind Institute. We set up a number of knowledge networks to support the Commission on Social Determinants of Health, and the Priority Public Health Conditions Knowledge Network reviewed depression. They said the level of evidence for low socioeconomic position was very convincing, low education, very convincing, unemployment, very convincing, and for food insecurity, gender inequity, and low income, very strong. Social determinants are clearly related to depression, and it starts early in life. In the WHO Commission and in all our reports since, we've talked about give every child the best start in life. These are British data from the Millennium Cohort Study, looking at socio-emotional difficulties at ages 3 and 5 by level of parental activity. So we asked parents, so there's the social gradient. The poorer the household, the greater the frequency of socio-emotional difficulties at age 3 and age 5. But we asked parents, is it important to talk to a child age 3? About 20% of parents deny that it's important to speak to a child age 3. And that follows the social gradient. The greater the deprivation, the greater the likelihood that parents will deny that it's important to speak to a child age 3 or age 5. Talking to children, cuddling children, playing with children, singing, normal stuff, reading books, all those things are less frequent as you go down the social gradient. And statistically, those parental activities, psychosocial markers, account for at least half of the social gradient in socio-emotional difficulties. Parenting activity make a huge difference, and you can see it very early on by age 5. Adverse childhood experiences from Perks. In a typical class in Central and Eastern Europe, this is children who have no adverse childhood experiences, 1, 2, 3, and 4 or more adverse childhood experiences. In England, if we look by level of deprivation, we can see a social gradient for incarceration of parents, drug abuse, sexual abuse, alcohol abuse, domestic violence, physical abuse, mental illness in the parents, verbal abuse, and parental separation. These are adverse childhood experiences, and they all follow the social gradient. The greater the deprivation, the greater the frequency of adverse childhood experiences. If we could prevent 4 or more ACEs, we could potentially reduce early sex by 1/3, unintended teen pregnancy by 38%, smoking, binge drinking, cannabis use, heavy drugs. Look at this, violence perpetration. Thinking about what I showed you on women being beaten up by their partners. If we could, in England, eliminate 4 or more adverse childhood experiences, we could reduce violence perpetration by half. And even more chilling, the victims of domestic violence are likely to have had 4 or more adverse childhood experiences. Incarceration, half, and I'll come back to incarceration. So give every child the best start in life. This is for the rich countries, OECD countries. Childhood poverty, defined as income below 60% of national median income. In Iceland, Czech Republic, Denmark, Finland, Korea, childhood poverty is 10, 11%. In the United Kingdom, 23% by this definition. In the United States, 30%. Wow. These are political decisions. Governments could take the action to reduce. The US, if it chose, or the UK, could have poverty levels the same as Denmark or the Czech Republic. It's a policy decision. And in those rich countries, we've decided we're happy to have children grow up in poverty, and that will damage their mental health and development. And you can see it. A league table of child well-being. This is for young people, teenagers. Mental well-being, physical health, and academic and social skills. The usual suspects always come top: the Netherlands, Denmark, Norway, Switzerland, Finland. The UK ranks 27th out of 38 countries. The USA ranks 36th out of 38 countries. These decisions, these policy decisions that we are making are affecting the mental well-being, the physical health, and the skills of young people. And we're doing really badly. This is in Alice Springs in the Northern Territory of Australia. And the largest building that looms over the town of Alice Springs is the Supreme Court of the Northern Territory, with good reason. If we look at the Indigenous Australians, Australian Aboriginals and Torres Strait Islanders in the Northern Territory of Australia, the incarceration rate is 2,400 per 100,000. For the non-Indigenous population, it's 186, 13 times higher in the Indigenous population. 84% of the prison population is Indigenous, compared with 27% of the general population. And among prisoners, 72% of males, 92% of women have diagnosed mental illness. It's a policy to put people with mental illness in prison, provided they are from a discriminated against ethnic group. And incarceration rates vary enormously. Japan, 48 per 100,000. The UK, 148 per 100,000. The US, 700 per 100,000. Wow. In Denmark, violent offending in 10% of males, 26% of females have mental illness. A UK estimate is 80% of all criminal activity is attributable to people who had conduct problems in childhood and adolescence. Whether it's 10% or 80% of prisoners have mental illness, it's a lot. Therefore, prevent mental illness in children. Take the steps to improve mental health in childhood. Not only will you get better mental health throughout the life course, better physical health throughout the life course, you're likely to get less crime and civil unrest. And the mind is an important gateway by which social determinants affect ill health. Mental illness and well-being, as I've just been talking about, and psychosocial pathways to physical illness through behaviors and stress pathways. Look at the US. Life expectancy declined 2 years in a row. In fact, it was 3 years in a row. That's 2016. It declined in 2017 as well. And a huge increase in unintentional injuries. Unintentional injuries include accidental drug overdose, 63,600 deaths. In fact, in 2017, it was 70,000 deaths due to accidental drug overdose, OxyContin and the like. That's psychosocial. Mental illness by another name, leading to an actual rise in mortality and decline in life expectancy. Absolutely key. And we've known about this in Scotland. A comparison between Glasgow, Liverpool, and Manchester, all with similar levels of poverty, post-industrial decline, yet Glasgow has higher mortality than Liverpool and Manchester. And the biggest relative excess are drug-related poisonings, alcohol, suicide, and external causes, all psychosocial. Harry Burns, the former Chief Medical Officer of Scotland, reviewing those evidence, said a major element of the excess risk of premature death seen in Scotland is psychosocially determined. Low sense of control, self-efficacy, and self-esteem in populations in these areas. So I come back. Social injustice is killing people on a grand scale. That has to be the motivation for what we're trying to achieve, to improve mental and physical health. And that's why I call what we're now doing, Build Back Fairer, put equity of health and well-being at the heart of all government policies. Thank you.
Thank you very much, Sir Marmot. Manasi?
Thank you very much, Professor Marmot. That was an excellent talk. Would you mind if we take a few questions?
That's absolutely fine.
Great, wonderful. So I can see that we have a chat where people have posted a few questions, and I'd like to invite Edna Bosire to flag off her question, please.
Thank you so much. Thank you so much, Prof Marmot, for a terrific presentation. And I like the way you end about trying to address health inequities by putting it in the heart of governance. But historically, we understand that pandemics have forced humans to break with the past and try to reinvent a new world. But in sub-Saharan Africa, we see a lot of multi-layered crises. We see violence, climate change issues, diseases of poverty, including HIV, tuberculosis, malaria, and now crises on non-communicable diseases and mental health disorders. And these crises are also overlapping with vices of power, systemic racism, and privileges. So I'm wondering, in the spirit of do something, do more, and do better, how do we begin, or how do sub-Saharan African countries really engage with reinventing or even responding to inequalities post-COVID-19? Thank you so much, and back to you.
It's a major challenge, of course, and the approach that I've taken, I push on a door, and if the door opens, I'll go in. But if it doesn't open, I don't bang my head against the door. I push on another door. And the reason at the beginning that I said one could work at the national level, at the supranational level, at the subnational level, or the jurisdictional level. Take my own country, which compared to sub-Saharan Africa has a light level of problem, not a deep level. But we've had national governments over the last 12 years that have not just ignored what I recommended in 2010. It's as if they took my recommendations and galloped off in the opposite direction. So working with national government has not been rewarding, but we've been working with city governments. The city of Coventry declared itself a Marmot city. Then Greater Manchester said, well, if Coventry can do it, we'll be a Marmot city region. We've got cities all around the UK saying we want to become Marmot cities. In Italy, they said, how could we create a Marmot city network in Italy? So I look for the opportunities to change. And in India, when we began the WHO Commission on Social Determinants of Health, in a way, I said what you just said. If governments are incompetent or worse, we're sunk. And Mirai Chatterjee, who's a leader of the Self-Employed Women's Association, said, no, if governments won't do it, we'll do it. So civil society. So in other words, we have to work at the level we can, whether it's civil society, local government. We're about to launch a network in the UK where we're trying to get partnerships between local government, universities, the third sector, with the voluntary and community sector, the police, the fire services, education, and business, all working together at local level. So my approach to this is saying, let's work at the level we can. And the other thing I should say is people often say to me, you're naive. Politics doesn't work that way. You're arguing for political changes. Politics doesn't work that way. And my response is, you're probably right, but that's not what I do. What I do is get the evidence. And as you can see, everything I argue is based on evidence, but present it in a spirit of social justice to try and engage the better instincts of people in a spirit of social justice. And we are getting take-up from politicians, not national politicians so much, but politicians at different levels of government.
Thank you.
Thank you so much.
Yeah, I know I want to pick up one or two more questions, but we'll come back to that. I know that Professor Zulfiqar Bhutta is going to move on to a next meeting. So in the interest of time, let me start by introducing Professor Bhutta, who will give some remarks on Professor Marmot's talk, and perhaps will pick up on aspects that he has so eloquently put out in his presentation. So Professor Bhutta is the founding director of the Center of Excellence in Women and Child Health, and he's a director of the Institute of Global Health and Development at the Aga Khan University, as well as the inaugural Robert Harding Chair in Global Child Health, and co-director of Sick Kids Center for Global Child Health. He leads large research groups in Toronto, Karachi, and Nairobi, focused on scaling up evidence-based interventions in community settings and implementation of reproductive, maternal, and neonatal child and adolescent health interventions in humanitarian contexts. I know that he has a very prolific record, and I want to invite him to kindly give some remarks, and then we'll follow up with more Q&A later on. Welcome, Professor Bhutta.
Well, thank you very much, Manasi, and it's almost impossible to follow Sir Michael in saying something on a subject that he has complete mastery and has led the world for decades now. So I completely concur with the ethos of Sir Michael's presentation, particularly around the pandemic having opened our eyes to so much that's already there organically, and also its influence on particularly the spectrum of the life course, starting with adverse early childhood experiences. I want to reflect a little bit on what we probably ought to have known before the pandemic, but didn't or did not implement. My group has worked on the whole impact of some of these strategies or mitigation measures, particularly around school closures and the missing middle of the school age and young adolescents that we really did not pick up in terms of the impact of the pandemic fell into the first year of the pandemic. And even then were not able to convince people to look at the better good, the long-term benefits. And a lot of the adverse effects of school closures on school-age children, the mental health consequences that we are now well aware of, were largely because of the inability to look at this in the context of existing inequities. And those impacts have been much worse. In South Asia, we believe that that educational gap that has occurred, the learning gap, is going to take a long time to reverse. And I want to just give you one statistic based on our own estimations on what's happened with girls dropout of schooling because of these measures during the pandemic, we estimate that close to around 450,000 unwanted pregnancies in young adolescents may have occurred during this period. And the consequences of that are intergenerational. So I think the issue right now is with something that we recognized as being absolutely a known consequence of this in ordinary times should have been much more on a radar screen in extraordinary times. And I hope, Sir Michael, that what may emerge from some of the scholarship, your work, particularly in Emerald region on building back fairer, is that we would have policies that would be a lot more evidence informed and a lot more focused on how we can do better. I want to reflect on some findings of recent systematic reviews that have looked at this issue, particularly mental health in children and young adolescents. And when you go through the risk factors that these systematic reviews done on literature produced in the last 2 years identify, I mean, they're the same as we have known for a long time as systemic differentials in various sectors of society: gender, female sex, younger age, financial insecurity, pre-existing conditions. I mean, I'm a pediatrician, so I'm very well aware of how children with existing disabilities and chronic conditions have suffered, and also things that we haven't really spoken about before, which is ethnicity as a driver of inequality. And we live in a region where this is becoming a lot more evident. But I want to talk a little bit about solutions as I close, because I think it's important for us to recognize that there are measures, there are interventions which do not necessarily require a revolution tomorrow, but we can move in that direction as we begin to recognize and manage this. And I want to pay a tribute to a giant in the field that we lost a couple of days ago, Paul Farmer, who I knew well, has certainly shown by example how things can be done in difficult circumstances and in within existing inequities. And some of my own work also reflects those learnings from his work some years ago in Haiti and in Rwanda. So the use of outreach workers and social safety nets that are there in the literature. But if you look at how many countries, exemplar countries who have done well during COVID, have benefited from that, it's a remarkable documentation of how we can collectively as a society do good. I believe many people felt at an early stage that Pakistan's ESAS program with the cash transfers was maybe a bridge too far. Maybe the country should not have spent that kind of money. But now when you compare and contrast how that intervention early on in reaching particularly the poorest of the poor women at that time, influenced change and influenced how people did not have to forcefully migrate from urban populations to rural populations. That's an exemplar in its own right. How community health workers, particularly women, volunteers, and for that matter, indigenous philanthropic efforts in communities came to the fore when it needed to support people who had absolutely no means of income. It's not enough, of course, and it always requires additional linkages with larger questions and larger issues within health systems. But I think there is, as I close, enough for us to ponder over for a long time. There has to be something wrong when the 10 richest billionaires of the world increase their wealth in a global crisis by $500 billion. If that's not benefiting from adversity, then I don't know what it is. And if we can allow that to happen at the cost of billions who are pushed into poverty, food insecurity, and deprivation, and long-term deficits, which Sir Michael has highlighted, then I think the world is a sad place indeed. As I close, I work in conflict areas in maternal and child health and nutrition. And one of the things that I remember is Kaisar Bengali telling us decades ago that unfair societies and unequal societies are sad societies because they breed despondency, they breed marginalization, and they breed violence. And as I reflect on what's happening on the world today, it is a sad world indeed, as Sir Michael pointed out, with conflict looming on the horizon. We need to reflect on how inequality and inequity, particularly in crisis times, also leads to despondency. So, Sir Michael, thank you very much for once again highlighting and underscoring these important, sad realities that we face. But at the same time, I think we are heartened by the fact that we can make a difference collectively, individually, and also as a society in addressing these. Thank you very much for the opportunity. And on behalf of the Institute for Global Health and Development that I lead, I want to congratulate Zul for putting together this webinar. And we look forward to further collaboration in this space. Thank you.
Sir Michael, did you want to comment?
Yeah, I do want to comment. I want to thank Dr. Bhutta for his brilliant comments, absolutely right to the point. I want to endorse everything he said. School closures. Actually, if you look at the life course, fancy having a baby in the middle of a pandemic when there's lockdown and difficult access to services. Fancy starting school and then having the school closed. Fancy going to university when you can't have personal contact, or doing final school exams. Right through the life course, this has been damaging people, and damaging people for life. There'll be a scarring effect that will be greater the more socially and economically disadvantaged people are. And we've got the evidence, it's crystal clear. And the reason I talk about Build Back Fairer is not just redressing the problem. We already had a problem of an educational gap. If you are unlucky enough to be born to poor parents, your chances were always less than if you were born to rich parents. And that was exaggerated by the pandemic. I hadn't known about the unwanted pregnancies, and I'd be grateful for the reference, a very important point. On ethnicity, in the PAHO Commission, we, for the first time, made it overt. We talked about structural racism and ongoing colonialism. And we see it within countries all over the world, low income, middle income, and high income. And structural racism has to be addressed. And on the billionaires, I'd pointed out that in the United States alone, the number of billionaires between March 2020 and October 2021, so in the first 20 months or whatever it is, 18 months of the pandemic, the number of billionaires went from over 600 to over 700 in the US, and their combined wealth increased by $2 trillion, from 3 trillion to 5 trillion. I don't think global health is all about vaccine equity. I think it's about much more than vaccine equity. But just think, the estimate is that it would cost $25 billion to roll out the vaccine globally. 25 billion. The billionaires increased their wealth by 2 trillion. That's 1,000 billion, 2,000 billion during the pandemic. Just think what would happen if there was a fair system of taxation.
Move on to introduce country-level panels. I wanted to start by introducing Dr. Simon Njuguna, who is the Director of Mental Health at the Ministry of Health in Kenya, and he is in charge of formulation and implementation of mental health policies and strengthening of mental health systems. And also I wanted to introduce a friend and colleague, Dr. Sameen Sidiqi, who is a professor and chair of the Department of Community Health Sciences He has worked for the WHO as a Director of Health Systems Development, covering Eastern Mediterranean regions. He will reflect on the ongoing action and challenges around building back fairer in his own countries with the eye on how social inequities impact mental health of their populations. So that being said, these two panelists have up to 10 minutes each, hopefully, to make their comments. Simon, did you want to start?
Yeah, so thank you, Dr. Zuri. So thank you for the very good introduction and the very good presentation. I would want to have about 3 reflections on this issue of social determinants of health, inequalities, and justice in global mental health. In our country, I would look at it from the work of the Task Force on Mental Health, and also on the work the ministry is undertaking on Quality Right Mental Health Initiative, which is also being undertaken in many other countries across the world. And then I also look at trying to make a case for mental health through making a case through mental health investment. And I'll start by the work the National Task Force on Mental Health did. This was a task force appointed by the president in 2019 and completed their work in 2020. And this was one of the key areas where the task force listened to the people on the ground to try and understand the issues around mental health and how it's well related with their day-to-day life. And many Kenyans were able to point out at all those domains in terms of social determinants of mental health. And looking at economic domain, political domain, environmental, daily life from early childhood, adverse childhood events, violence within community, and even politics. And surprisingly, what they're able to come up with was that most people were able to identify that these determinants of health were a major contributor to issues of their health, to the issues of inequalities and injustice, especially to persons with mental illness. And within that framework, the task force made a number of recommendations to try and address some of these issues, trying to have all policies across all sectors, try to make an assessment on what impact they have on mental health, so that they can be able to address issues around the determinants of health beyond the sector of the health sector. And then also looking at policies towards social protection and looking at anti-poverty reduction policies, and also addressing the issue of stigma. But very quickly, let me go to one of the areas where the ministry is working on. And this is something I would really emphasize across the world because it's highly recommended by the World Health Organization. This is on the Quality Right Mental Health Initiative. Go to the first slide. The Quality Right Mental Health Initiative is trying to look at the 4 objectives to try and build capacity to combat stigma and discrimination and promote human rights and recovery. See a way in which mental health are addressed from the community-based services which support and respect and promote human rights and recovery. Address the issue of a civil society so that they can be able to influence policy and conduct advocacy. And this goes even including the persons with lived experience. And then reforms in policies and legislation. This is based on the United Nations Convention on the Rights of Persons with Disability. I would say this is a framework and an initiative which will play a key role in trying to address these inequalities and injustices and go further to promote the issues of determinants of health, to look at the root causes which most Kenyans told the task force are key determinants or drivers to issues around ill health within the country. Beyond this, we went further to see how can we make a case so that we can convince all policymakers across the sector that these need to be done. And the best way we saw was to do a mental health investment case, trying to see what is the cost, both to the economy as a result of ill health, and trying to see what would you get as a return by having evidence-based interventions and what the country would lose in terms of loss of productivity, violence, good economic development, if we are able to address the injustices and inequalities around mental health. So going this way has been a very good effort. We have completed this investment case and we'll be giving the results. It has shown that actually investment around areas like depression, anxiety, alcohol use disorders, their returns are high by many folds, if in terms of what the country will get in returns. Also, again, making interventions on evidence-based interventions like addressing school health, school mental health, addressing issues which can reduce those childhood adversities will have major returns in the health of these children's 10, 20 years later on. So I think those are my major reflections on those three areas. And what we found from the task force, the initiative we are doing, the Quality Right Mental Health Initiative, and the study we have just concluded on mental health investment case. So thank you, and I'll be ready to answer any questions or any clarification.
Thank you very much, Dr. Njuguna. Any questions, any quick questions? If not, at least I would like to say on behalf of the government of Kenya has been very forward thinking. And I was very impressed by the fact that they not only published the task force report almost unedited, there were a lot of negative comments in there urging the country on to move on to take action. But the fact that then they launched an action plan actually to tackle some of the issues that were highlighted in the task force. And we have on our panel Dr. Lukoye, who also participated in that original task force. I don't know whether, Lukoye, you might have a comment or two to make.
Thank you very much, Zul, and thank you, Prof, for the very enlightening presentation, and Zulfi and Simon for the very illuminating comments. I think in this part of the world, mental health has almost can be said to have come to its own, in the sense that the president himself has declared this an emergency and has declared that this is something that is part of his legacy projects. He has lent his own personal support and that of his government to a lot of the initiatives that we put into the task force report. I think this is in response to a lot of the advocacy work that went on in the Kenya Psychiatric Association under Dr. Njuguna, as well as other supporters who came in very strongly to support this. I think in relation to today's presentation on inequities and so on, one of the biggest concerns that we have in this part of the world is that for a long time, the international health community and the places that put in place resources for health, for a long time they have promoted an inferior kind of inferior interventions for people who are poor, by putting forward the argument that because you're poor, then you can't afford current evidence-based interventions to support the people come out of situations that increase the risk of mental illness, or to manage people with mental ill health. I think I like the reference to the late Dr. Paul Farmer, who flips the question and asks, given the magnitude of the good things that we can do in this population, what resources do we require in order to do what we must do? Rather than starting with, given the low level of resources we have, what can we do for this population? And I like that formulation, and I see that this is at the root of the fight for equity between countries and within countries, where, as we have seen in Professor's presentation, that people who are wealthier, areas that are wealthier, definitely tend to do better. But even within the same countries, deprivation, inequity has health implications, has lifespan implications, and so on. So there are many lessons to be learned. And in Kenya and East Africa, we are keen to use the lessons that are being learned in those other countries, lessons that have been learned historically, to ensure that, as has been presented very well, we build back fairer rather than just focusing on building back better. Thank you.
Thank you, Professor Lukoye. Maybe now we can move on to Dr. Sameen Sidiqi for his comments. Dr. Sidiqi.
Sure. So thank you very much. Thank you, Zul. And it's always a pleasure listening to Professor Marmot and colleagues. I have been compelling, the presentation has been so compelling, so that before I start talking about what Pakistan's situation is and the challenges are, I'd like to reflect very quickly on a couple of points. I mean, the evidence that Professor Marmot presents is just so compelling, not just from a country or a region, but really it's truly global evidence from Latin America to Far East and what have you. But the point that I'd like to bring up is that, yes, that evidence is powerful, but what do we now do and how do we tell these countries and to be able to address this? And of course, there are some brilliant examples, and you're absolutely right. The example of SIVA in India, read by Meera, is one of the glaring examples of how a civil society can lead the work. But I think there are a couple of points which I would like to touch on very briefly. And one is, it's underpinning a lot of this are issues of governance, both within the countries and also global governance. And we're talking in the context of global health governance, and I think issues of lack of accountability and transparency, lack of participation are some of those underpinning factors that lead us, or that lead ultimately, not to forget that, these are lots of countries suffer from high levels of corruption in our countries, which actually is one of the underlying reasons of why. And one of the aspects of that is that we should also be looking at, and Professor Marmot, towards the end, I would like your guidance and advice on how do we look at the political economy of social determinants of health in these countries? And you've pointed to so much evidence, but underpinning this are challenges of political economy. And I think some of that needs to be looked into perhaps in greater depth. Before I move on to this, I think there are 3 or 4 areas in which certainly, and in the context of Pakistan, I certainly see underpinning a lot of these. For instance, unless we try and address problems of our judicial system. I mean, we're talking social justice, but in our countries, if we have the most non-functioning or disruptive judicial system, I don't see how people will get justice, The governance I've already touched upon, The role of the media. I mean, the media in our countries has become so powerful, but it has to be directed and engineered to move in a direction to promote these kinds of values such as social justice and equity. We've talked about civil society, and certainly last but not the least, the role of academia, the traditional academia. I'm not talking of UCL London, or not talking of the work led by Professor Marmot, but by and large, academia has shied away from working in these areas. And I think we need to be coming much more forward to be able to address these and to bring about some of those issues, raise those issues before our policymakers. So that was just some of the reminder of the work that I had the privilege of doing with Professor Marmot many years ago. Thank you for bringing those evidences back. Now, coming to the context of Pakistan, and I'm going to come from the mental health perspective, although I'm not myself a mental health person. I worked much more, and I have worked many years or many decades in health systems. If you just look at the burden of mental health in Pakistan today, I can tell you that 30% of all disabilities that happen in health in Pakistan are due to mental health. And that's a lot, actually, Underlying a lot of this huge burden of mental health in Pakistan is the whole range of the things that Dr. Marmot touched upon, which are the social, cultural, economic, ecological, demographic, and geographic determinants, very recalcitrant structural determinants that are very, very sometimes difficult to tackle. And I was looking at some of the literature, and things like intimate partner violence in our parts of the world, leading to a lot of challenges and depression and health problems in women, or things that Dr. Marmot talked about: unemployment, food insecurity, poverty, migrants. We know we have just now gotten migrants, people who have just moved from Afghanistan into Pakistan in the last 12 months. Now we have 2 million Afghan refugees there, people living in, and then ethnic minorities. Pakistan, I have to say, we are calling ourselves Islamic Republic of Pakistan, but really we have challenges with our ethnic minorities. Religious minorities are extremely challenged in our countries, and of course, not to forget so there are so many underlying determinants. Now, in terms of the research in this area in Pakistan, not much has been done, but it's not that nothing has been done. There are evidences that we can call upon, and there has been work, for instance, in Karachi, where it has been shown that almost 2/3 of the women have had or faced some sort of mental health problem. They have depressive disorders for all sorts of reasons, life satisfaction, loss of personal income, or continuous stress in life. There are lots of evidence around child health problems, and that relates a lot to schooling, the quality of teaching, the education, the level of dropouts, and living in urban neighborhoods that are rough, and so on and so forth, Similarly, there's evidence from South Asia. I mean, Pakistan is one of the key countries in South Asia. Intimate partner violence, unplanned pregnancies, male gender preference, poor relationship with in-laws are all features that lead to depression and mental health problems in those communities. And so those are some of those underlying reasons why. In my own department, my colleagues have done some work, and I want to touch very briefly on two of those. My colleague Waqas has just done a study on looking at the dignified maternal care intrapartum. And while we're talking of within the health system, but even within the health system, women, when they are birthing, are not necessarily getting any dignified mental, and that is or a contributory factor to their depression or PTSD and so on and so forth, and he has found that if we do something to be able to offer them better care, it does make a difference to the level of their depression, the level of their stress. We have just also completed a study on over 1,000 health workers in 23 districts of Pakistan who have been, faced with COVID. And I can tell you that there have been huge problems and challenges that they have faced in terms of their burnout, and what we have proposed is that they need psychosocial support as healthcare workers. They need informational support because there's no supervision, communication. They need instrumental support. You don't provide them the best environment in terms of giving them the PPEs or giving them that support, and, they will then suffer these kinds of burnout. So these challenges exist. Now, coming to a bit about mental health services, we don't spend anything on mental health in Pakistan. The level of health expenditure is around 0.4% of what the government spends on health goes to. So if the government of Pakistan spends $100, then 40 cents of that barely go to mental health problems, and that's a pittance. So unless we start addressing some of those issues, I think these problems will remain. So, and not to talk about the shortage of health workforce that is trained in mental health and so on and so forth. So in terms to sum up what I've just said from a Pakistani perspective, of course, I think there's a need for a lot more research looking at the underpinning reasons for the social determinants of mental health. Some I have very briefly touched, but I think there's a lot more work that needs to be done. But I'd also suggest that the research has to be much more from an interventional perspective than just looking at the causes of causes, because I think we need to look at what works and what doesn't work. And I think that's a gap in the kind of work that needs to be done, And before I close, I think we also need basic, essential mental health services in our primary care system at the community level and at the primary care level. And I have no hesitation in saying in the rural area and the field side that I work with the government, there is hardly any mental health service, and so where do people go when they have a problem? And finally, we need to address both of these, not just from the supply side, but equally from the demand side, because unless we target and bring up programs that raise the importance of mental health and destigmatize mental health as a problem as something which is a serious stigma in our society, we will not be able to address this. So there's a lot to be done, but I'm glad that there's a lot of movement that is going on. On the positive side, before I finish, I think I should be very fair. The government of Pakistan has now very recently come up with its mental health action framework 2021-20. It just came out in November last year. And it is part of the NCD program, but mental health comes out very prominently. So on a positive side, and I want to finish on that positive note, is that there is a clear desire, commitment, and understanding. And for the first time, there is a very good document that the government has produced in terms of a mental health action framework, which I hope would lead to a much more organized, systematic program towards mental health in Pakistan. So I'm going to stop here. Thank you very much for the opportunity. And it's always good to reconnect with all of you. And Professor Marmot, it was a privilege listening to you. Thank you. Thank you so much.
Thank you very much, Sameen, for very succinct points that you're bringing about the interventions and the problems that exist in our systems. Every geography seems to have problems for sure, but very unique problems that need to be addressed in a very contextually sensitive way. Dr. Marmot, sorry we had to we lost you for a while, and you were amidst making your comments. So I don't know whether you wanted to resume your commentary, or do we move forward?
I always think we should move forward as a general principle. But let me just comment on the earlier question that was raised and what Sameen Sidiqi just said. It can look overwhelming. If you look at the democracy index that the Economist Intelligence Unit produces every year, it ranks 167 countries on the strength of their democracy. Norway is number 1, North Korea is 167, and the number of countries with a full democracy has gone down. Even the strength of many democracies has got worse. So it's, I always like the data, because if you're deciding whether to be depressed or cheerful, you could do it on your emotions, or you could look at the data. So on the one hand, if democracy is a good thing, and I'm reflecting the countries that I've lived in and grown up in, I think democracy, as Churchill said, is better than all the rest. May not be great, but it's better than the alternatives. So if you think democracy is a good thing, things are slipping back. Wow, that's pretty depressing. And all the issues that Sameen talked about of transparency, accountability, participation, corruption, key issues, and it's not a very rosy picture. On the other hand, global health has got dramatically better. It's got dramatically better. When I was writing The Health Gap, I pointed out there was a watershed moment when life expectancy for the world was greater than the Christian Bible's 70 years. So the world life expectancy had achieved, we were so far short of that 70 years on average. Now we think only 70? That's not terrific. You know, if you, in Hong Kong, a woman in Hong Kong, life expectancy is 87. 70 doesn't seem terrific. You could be 87 if you're in Hong Kong. So it's not grounds for complacency, but it's a reminder that things got so much better. I think we are in a dark place at the moment, relatively speaking, but I don't think that it's terminal, that it's all over, that we're in it, that democracy's gone, that gross inequality is with us forever, and these problems can't be addressed. I think they can be addressed. And it takes all of us working based on the evidence and in good faith to address those issues. So it can look overwhelming, but I think we need to remind ourselves, based on the evidence, not to be overwhelmed, but to address what we can do to make change. And there's much that we can. And just as Sameen finished with the Pakistan government, we know through long experience that a government producing a strategy is not enough, but it's a start. It's better than not producing a strategy. And then it takes all of us to implement that and make it work. So yeah, there's ample reason to be concerned, but that should just give strength to what we need to do to make our task even more urgent.
Thank you, Sir Marmot. I think those are very wise words, and certainly we need to continue to be encouraged and empowered to make change, because change doesn't come easy. I mean, obviously, it takes all of us to kind of move things forward. And I think if we get overwhelmed, then nothing will happen. And so I think the onus is on us to really find even the smallest sliver of hope and drive it through. And as you were saying, knock on many doors. Whichever one opens, you go for it. And the different doors will open up at different times. So we don't have to make it sequential, but there is a lot of opportunity. I also wanted to comment on the fact that we have been talking a lot about vaccines and dealing with COVID and the realities of COVID, but I think we now need to start talking about behavioral vaccinations. There are methodologies whereby we can empower people and really bring and vaccinate them against the effects of the adversities that they face, or to deal with them better and make them more resilient and kind of moving out of those adversities that we all face. And we can't probably change them all that quickly, but we can certainly do a lot of things on the front lines to help people be better, feel better, thrive, and not only just succumb to the negativities that engulf the entire field. Let me now maybe move on to the last segment of the webinar, and that's to get a bit of the World Health Organization perspective. And I wanted to introduce Florence Baingana, a psychiatrist, a public health specialist. She's currently a WHO African region advisor on mental health and substance use. And I'm proud to say that she has done a lot of work across Africa, of course, but including in Uganda, where I was born. And WHO has given the social determinants of health and impetus around getting together these orders to build back better and just equitable societies. So with that, can I turn the microphone to you?
Thank you very much for that kind invitation. I didn't know I had a fellow Ugandan with me here. That's really good to hear. Yeah, it's been really interesting listening to all the presentations, and of course a huge pleasure to hear Sir Marmot speak. Very, it's just so much to learn every time I listen to him. Giving a very brief overview and providing more of Africa region perspective on this, I want to use just the next slide. It's a one slide just to talk through using the social determinants of health as was presented in the Lancet Commission on Global Mental Health and Sustainable Development. And all these are things that have been touched on, but just to put a lens, an African lens to them. The African region, as we know, has a very young population, and this becomes much more critical when we think about the social capital. If we come to the last one, social and human capital, a young population that is growing up, very many of them with very little or minimum or very poor education. We also know that a lot of this young population is actually living in large cities. Safety and security housing structure, if we look at the cities that they are growing in, Africa has has the biggest slums. Two of the biggest slum cities are in the African region. And the populations here, I mean, the cities here are also projected to grow exponentially in the next years up to 2050. And this growth is going to be in slum cities. So things to worry about, some of the things talked about, like alcohol and drug abuse and crime, inner city crime and things like that. The other thing that was touched on is the gender equality or inequality. gender-based violence, IPV, we know that a lot of that was reported anecdotally as a result of the COVID. When we started off in the early 2020, soon after it was announced as a pandemic and there were the lockdowns, a lot of people had not been used to living together in a closed space for that length of time. Some people also resorted to alcohol to try and cope, but what the result of that was a lot of gender-based violence, a lot of intimate partner violence, the teenage pregnancies that were also talked about, and children dropping out of school. We also know that a study was done by the Ministry of Education of Uganda as an example, looking at school achievement for the students who had been out of school for 2 years, because Uganda closed its schools for 2 years. They only went back this year for the first time since 2019, end of 2019. And what they found actually was that the high income school-going children had remained on track. They had actually moved a year ahead or 2 years ahead because they continued with online education, or the parents could pay for tutors, or they were able to keep up, and they actually continued on grade, whereas the low-income students did very badly. So again, that income inequality impacting on the outcomes for education. And of course, this is going to be felt all the way down going forward, meaning that for those low-income children, many of them who actually dropped out of school even this year because the parents could not afford to pay for them to go back to school. So it becomes a vicious cycle that we cannot run away from. Coming to the trauma and violence, the Africa region right now has about 127 events, ongoing events. So it's not just the COVID, but we have floods and we have the conflicts. We have 11 different humanitarian crises. 3 of these are protracted grade 3 crises: Northeast Nigeria, Northern Ethiopia, as well as the DRC. These have been ongoing. The children growing up within these conflict-affected areas, as well as the populations in general, definitely having the wrong end of that stick. I will move on from that to just reflect a little bit on some of the things that were mentioned, because there was a mention of we need to focus on interventions. We cannot just focus on the challenge, and I hear that very much. And I think one of the areas where we would want to be putting a focus is on child and adolescent mental health, because they are a big population in our region. And as Professor Sir Marmot talked about very eloquently, the need for us to intervene early in order to offset what could happen in later years. This was also very well reported on in the UNICEF State of the World Children Report for 2021. It looked at the possible returns on investing in school health education program, mental health programs, and the return on that investment. Some countries like Rwanda have actually invested in school mental health interventions, and these are countrywide. It's not a pilot, it is being rolled out countrywide. So that is one country that I can report on, where health and education are working together to see what they can do for children, providing targeted and universal school mental health interventions. The other one is we need to see, and I think somebody may have mentioned this, to see how do we have a government-wide commitment and a government-wide response, because it may not be initiated from the health sector. This is a very complex issue with multi-sectoral components to it. So health trying to initiate a response when some of the issues are to do with climate change or to do with conflicts or to do, with the way that cities are organized, it's a very complex issue. And therefore there has to be a government-wide commitment and a government-wide response. I believe Kenya is the one that I can quote as being closest to that in our region, where the president himself prioritized mental health. And therefore, all the other sectors have to fall in. So it would be then up to the Ministry of Health to ensure that they do bring all these other sectors on board, as long as they have the backing of the president right now, because this is the only way that we can move this forward. I guess the other country I could talk about is Zimbabwe, because most of our African countries, unfortunately, are also having to deal with an epidemic of alcohol and drug use. But Zimbabwe has actually established a commission, and this is again led by the president directed, and a response has been put in place with all the different sectors of government to respond to the alcohol and drug use challenge there. But that one is specific to alcohol and drug use. As WHO, I'm sure you all know that last year, the Global Mental Health Action Plan, the annexes to that were endorsed, and it was extended to 2030, which is a very good thing. As the regional office, we are actually in the process of developing a regional implementation framework to implement the global action plan in the African region. And this will be presented to the regional committee in August of this year. And in next year, at the same time, we are working to get a situation analysis on mental health and psychosocial support, the issues as well as possible solutions. And this will be a report this year developed into a strategy for next year to be presented to the regional committee in 2023. This would then provide guidance to the countries on what they can do in the area of mental health and psychosocial support. We have held regular meetings on mental health and psychosocial support. We had one last year in June, and we had another one actually the last 2 days on Tuesday and Wednesday, again, a regional meeting. So these meetings are going to be regularly held about every 6 months to provide support to the countries. We also have Zimbabwe and Ghana being the two special initiative countries where we hope to implement in a concerted and coordinated way mental health plans. They develop a strategic framework and then they implement it in a coordinated manner. I will stop there for now, but just to say that the WHO is committed to do what it can and to support countries and to work with partners. So we do work very well with UNDP, with UNICEF, with other UN agencies, and we shall continue to do so. Hopefully, I'll be taking a lot of learning from this session and translate that into some of the responses we can provide to the member states. Thank you very much.
Thank you. Manasi, did you want to take it from here?
Thank you very much. Yes, indeed. Thank you for all the comments and for a wonderful presentation and all the effort you've all made. We will carry out, this is a Q&A round, and I have received some questions, and this is open to all panelists. Invited Professor Marmot, one of the things that he asked me was, what action are we going to take going forward? And I want to ask the esteemed panelists here, what next steps are we going to take? We've been discussing some of those here, but are there any next steps that we can take as a collective right now and report back and come back again and discuss some of those? Are you hearing some areas that we must make rapid, immediate progress? So that's an open question to the panelists.
And I think I'll also just point out that Diana has now joined and she's probably ready to speak.
Okay. Diana, do you want to ask a question now?
Thanks, Manasi. Can you hear me okay?
Mm-hmm.
Thanks, Manasi.
Yes,
I was
go
just
ahead.
curious. I haven't got my question that I had prepared in advance in front of me. I'm sorry. But I think the essence of what I was interested in is that as we think about the social determinants of health, the economic determinants of health, what is the role of the private sector in these discussions? And given the influence of industries and firms in these issues, I would be very interested to hear Sir Michael Marmot's thoughts about that. I think it's an area he's probably looked at in the past, but doesn't often get the attention in these kinds of discussions that I think it might warrant given the influence. Thanks.
Would you like me to respond?
Yes, sir. Yes, please.
Well, I'd say that there's at least two, it's a very important question, and there's at least two components. I mean, when we were doing the WHO Commission on Social Determinants of Health, we asked ourselves, what about the private sector? And we got nowhere. We didn't know how to get involved. So now, firstly, let's think about the global issue. If you look at tax avoidance by multinationals, in the EMRO region, I think in Egypt, if I'm remembering the figure, the tax avoidance by multinationals amounts to about $2.5 billion a year. And in Saudi Arabia, it's 2 billion. In country after country, a rich country, a middle income or high income country, multinationals are not paying tax. They're very good at it. In the UK, Starbucks paid no tax. When they were asked in the Parliament, in the House of Commons, why do you pay no tax? And they said, because we don't make a profit. And I thought, that's so sweet. Isn't that kind of them? Starbucks is operating in Britain for the well-being of the British population. They're doing it out of the goodness of their hearts at no profit. It's so kind of them. Why don't they make a profit? So when you start to look into it, they buy their coffee beans from the Netherlands. The Netherlands? They don't grow coffee in the Netherlands. They grow tulips and moo cows. They don't. What's going on? They grow accountants in the Netherlands. So it's an accounting trick. They pay a huge amount of money to the Netherlands for their coffee beans, but they don't grow coffee in the Netherlands. The Netherlands coffee comes from, Costa Rica and Brazil and normal places. So they don't pay tax. They make vast quantities of money. Google, Starbucks, they just don't pay tax. And that's got to be solved globally. You can't solve that within any one country. So the multinationals have a huge role to play here. And some of the international trade agreements are worked out to the benefit of the multinational corporations, not to the benefits of the people. I mean, it's possible anything that President Trump was against, you could be for. But so he was against the Trans-Pacific Partnership, so it must have been a good thing. But when you look, for example, the Transatlantic Trade Partnership, part of it is to privatize the National Health Service. The investor dispute resolution mechanisms are all in favor of corporations. So if you're working in Nigeria and you're polluting the ground and the rivers, then you've got this dispute mechanism, which is weighted in favor of the multinationals. So the system is rigged, and it's got to be unrigged at a global level. No question about it. But there's a second response, and that's at the level of the individual corporation. or small and medium enterprises. And for the first time in the UK, my Institute of Health Equity and I are working with business. Legal and General, which is a big financial institution, insurance, it has close to £3 trillion of investment. That's a lot of money. And they approached me and said, we'd like to see how what we could do could improve health equity, reduce health inequalities. So we're just in the process. We're going in April, we're going to launch a report, which I hope will be of more general interest. And we say there are 3 domains in which corporations can be active to improve health and health equity. The first is employment practices. Unemployment is bad for health. Employment can be good for health, but it's got to be good employment. The gig economy, insecure contracts. When I was talking about EMRO, I talked about people who don't have any contracts. They're in the informal sector. So improving the quality of employment can be good for health. And that includes paying conditions as well. The second is goods and services. The majority of the world's population do not live, the majority live in cities, do not produce their own food, for example. So we're dependent on industry for supply of food. Food, without food is a bit like employment. Without food, we die. With food, it can be good for our health or bad for our health. Working with corporations to try and get on the good side, but not just food, all the products, goods and services that corporations are involved in. And the third, we've been talking in countries about the healthcare sector as an anchor institution, having a broader impact on the community in which they operate, employment practices, environment, purchasing, and the like. So now we're talking with business as becoming an anchor institution. Looking, some businesses already talk about ESG, environment, social, and governance. We've now got Legal and General talking about ESHG, environment, social, health, and governance. Look at the environment, social, health impact of what you do in communities. So then the question is, why should business do any of this? Well, I noticed a question in the chat about ethical questions. I am naive, I know that, and I'm proud to be naive. But I think the ethical questions and the practical questions come together. I don't think it's too difficult to make the case that what's in the interest of businesses' profitability is also in the interest of their social responsibility. Be a more socially responsible business, and you may well become a more profitable business. So the 3 domains that I've talked about, the case that we're making is come to the party with us in employment practices, in the nature of the goods and services in which you trade, and the broader impact on the society. Come to the party with us. My motivation is ethical, but it's practical too. Not only will you have a positive impact on health and health equity, it'll be good for the long-term future of your business.
Is that okay? Okay, great. I was just thanking you and saying that I was going to point your attention to the question on ethics in publications and research that Dr. Murad Khan talked about. And on that note, would you mind, given that a large number of our audience are young scientists, researchers, medical students, would you want to ponder a little bit about how they can go about addressing social determinants of health in their work, in clinical work, as well as in research. Some pointers to that, Professor Marmot, and any other guidance from the panelists is also very welcome at this point.
I've been thinking about this a bit lately. A member of my family went to doctor about something or other, and the doctor said, "What do you do?" And my family member came back, said, "This doctor had never heard of you." And I can live with that. That's not a great blow to my narcissism. I can live with that. But I think, but what I found myself thinking is that doctor should have heard of me, not because of me, but because I want all doctors to be concerned with health equity. Whatever you do, whether you're dealing with orthopedics or psychiatry or whatever you do, what you do should be in the context of the kind of ethical framework we're talking about, social justice and health equity. Just read the British Medical Journal and the Lancet. If you're not reading the medical journals, what's wrong with you? You're some kind of technician. And so what I would say to young doctors and medical students, whatever branch of medicine you go into, whether, as we heard in the discussion, whether it's maternal health, maternal and child health, obstetrics and gynecology, pediatrics, geriatrics, internal medicine, surgery, whatever branch of medicine you go into, put it in a context, put it in the social context. Who is being served? Are you just treating people and sending them back to the conditions that made them sick? Put it in that context. We should be striving for the better health of our populations, not just the individuals in front of us, and a fairer distribution of that health. So I'm not going to say to any student or young doctor, you should go into this branch or that branch or public health or pediatrics, or that's up to them. But I would like all people, doctors, nurses, healthcare professionals, to be thinking about the broader context of inequalities and how what they do is addressing these issues.
So I'd like to just follow up on Professor Marmot's comment. I think thank you very much for raising that. And I want to say that not necessarily in the country, but in Aga Khan, in our medical college, in our nursing college, this aspect comes out quite prominent as actually. And so not that I have done it, but it has been a tradition in AKU that public health and health equity and those kinds of values of justice are instilled in our undergraduate students. And I think that's where we need to catch them, and that should be the part and parcel of the curricula at in medical schools, in nursing schools, and other allied health professional schools. And I think that's where much more emphasis is needed by our medical councils of our respective countries. But I'm very proud that in AKU, we give a lot of emphasis on this, and we have lots of debates on this as part of the curriculum in our program.
Exactly.
That's wonderful to hear. Would anybody else from the panel like to remark on this question around how do young people go about addressing this? Any other feedback?
Yeah, I think Manasi, today's public spaces belong to the young people, especially in this part of the world where 2/3 of the population is under the age of 35 or under the age of 30. And I think their voices do matter, even though it might not feel so when they are doing things individually, but their voices do matter. And they have organized themselves in many different ways. We have, professional associations with many young professionals. We have advocacy groups with many young people in them. And I can tell you for a fact that a lot of the impact in mental health in Kenya and some of the things that made the president make this a priority are the voices of young people in advocacy on social media and in public places saying that mental health matters and that it is time, to take action. And this eventually reached the powers that be because the voices of young people were intertwined in this messaging, and the young people designed the campaigns, and the young people knew just the right things to say that resonate with other young people, but also resonate with the politicians who need to listen to young people because they need their votes. So I think young people are not powerless, and their voices matter. And that is the attitude I would take as a young person going into a public policy space and use that power to make a change for good. So thank you.
Yeah, and I think I resonate with the comments that Prof. Lukoye is making. And I think that the youth are, for the first time, the reason the stigma is dissipating for things like mental ill health is because of the youth. They are less afraid to talk about mental ill health. They don't carry as much stigma. And I think that we will learn a lot from them. And they need to carry the torch forward because the future is for them to make. And I think we need to empower and enable and educate some of the core factors that influence the mental well and physical well-being. One of the things that we had done in the past, not that long ago, is we had launched a hackathon for students to start contemplating about their mental health challenges and to come up with their own solutions. Like, how would they like to be treated? How can they find solutions that maybe us, the older generation, are not able to give them the kinds of tools that they require and the strategies that they need to deploy. And so they came up with fantastic ideas, and they were incubating those ideas now to kind of move things ahead. But in essence, yes, youth need to take charge of the agenda because, frankly, we have failed them. And the generation belongs to them. We left them environmental mess, economic mess, health system mess, and no wonder they're despondent, but they will rise to the occasion. I have every confidence that they will pick up the baton and move forward.
Thanks, Zul. I want to make sure I read out one or two comments directed towards you, Professor Marmot, by our people who've joined us. This is from Matthew Mutiso. On the structural drivers, is it okay to include law and access to justice? Example, laws on suicide, criminalization, drug laws, petty offenses laws, etc. And I want to read one more comment before I invite you to comment on these. This is from ACAR. The prevalence of private healthcare and the abuses associated with that damages trust, unnecessary treatments, and can push people to poverty. Those who cannot afford basic care have to learn to live with disability and early death. And I know that you'd agree on many of these. Would you want to comment on any of these?
I think the law question is terribly interesting. At several levels, law can, and the criminal justice system can be a means of social control. And I showed you those figures for incarceration, Japan, the UK, and the United States, 700 per 100,000 locked up. It's a means of social control. And the whole movement of defund the police in the US in relation to Black Lives Matter was, I think it was over the top. I don't think there's any democratic consensus in the United States for defunding the police. So it was obviously over the top, but it was a reaction to, murdering a Black man in full view of the public is almost beyond belief that a policeman would do that. But if you ever wanted a statement of the law as a means of social control, there it was, with the knee on the neck of a man who said, "I can't breathe," and then you kill him. So that's the bad side. And we're familiar with it. The good side is, for example, I've been talking to the police in Britain a great deal about how we can make common cause on prevention. I showed you the link between mental illness and incarceration, and enlightened chief constables, senior police officers understand this. They understand, they don't see their job as social control. They see their job as trying to make the community safe. And one way of making the community safe would be to prevent crime. And to do that, they could make common cause with those of us who want to prevent mental illness. And then so I said there were two strands. Then there's a third strand. And I had a conversation recently, a public conversation with Health Justice Australia. And I've talked to law centres in the UK, which is helping people achieve their rights. If we take a human rights approach, then the law is an important mechanism to help people realize those rights. They're not gaining access to the law or to society because of the obstruction, one way or another. And in many countries, we see that access grossly unequal. If you're rich, you buy legal access, and if you're poor, you don't get it. So there are lawyers working in the service of distributional justice, not just criminal justice, but distributional justice, helping the disadvantaged part of the population gain access to their rights. So I think for those three reasons, there's a clear role for the law. And on privatization, I mean, once you charge for anything, you do two things. One, you no longer declare that whatever it is you're charging for to be a public good. Mm. And second, you raise the issue of inequities.
Yeah, no, absolutely. I think absolutely. I mean, one thing I know we have to close very soon. One lesson that I think I took away from your work is for mental health specialists, especially, to differentiate between inequities and disparities and just the issue of access-related problems. We get very, we get bogged down by access, but do not look at broader structural issues. And I think you in your book, you put it, you help us understand that those are different things and disparities is a broader issue. I think the second thing that I took away is that, which is something that has come out from a WHO report, I don't know who said this, that with regards to mental health, all countries are developing countries. So we have to make sure that there is a progress across the board. So I want to sincerely thank you, Professor Marmot, and I would like to hand over to Professor Merali here to give a vote of thanks, and to our great panelists who made this event possible. So Zul, over to you, please.
Thank you. Thank you so much. So first and foremost, I wanted to thank Sir Michael Marmot. Not only are you an inspiration, but you are tenacious. And I think the world needs you, and world needs your guidance, because we all want a better place for our children and grandchildren. And so thank you. I think that your championing of health, equity, and social justice couldn't resonate more with all of us in the world. So thank you for continuing to fight this fight, and we are behind you. I wanted also to thank the panelists for taking the time and digesting the information and contributing to the theme of how can we really work towards making a world a better place. And so I think your thoughts and your comments were very well appreciated. Also wanted to thank all the participants who are silent behind the scenes, that are participating in this webinar. You can see that people have been sticking with this for a couple of hours. Just goes to show you how interested not only we are as panelists, but a community at large is very interested in this subject matter. And so thank you all for having stuck through a long but very exciting debate. And then finally, I wanted to say a special thank you to Manasi, because she was instrumental in getting this webinar together. And it took a lot of time, effort, and thinking to kind of get all the participants organized in a way in which the whole thing could be packaged so that it makes cohesive sense in terms of moving the agenda forward. So thank you, Manasi, you did a great job. And thank you all. And see you next time at one of our series. Bye-bye.